why we do biopsies, what is the idea of doing radical prostatectomy, how the pathology report matters to the clinician, what it means to the patient, and that's what we are going to learn today in an hour and hour and a half. So this is some disclaimers which I want to show, that this presentation has some cartoons and smileys just for the educational interest, and some images are for humor, but no, not disrespectful to the patients, and there is no breach of confidentiality of the patients in this presentation. So case 1, we have a 73-year-old male with lower urinary tract symptoms since 6 years. So maybe I can start with Shivani. Shivani, what do you mean by lower urinary tract symptoms? Do you know what it means?
Yes, sir. It includes frequency, urgency, and dysuria.
Okay. So patient has micturating symptoms, and generally this is as a part of sort of aging. Most of the males will have some kind of prostatic hypertrophy, and this is a very usual symptom which elderly males will present with in the urology department. So every lower urinary tract symptom doesn't mean that the patient has got cancer, but then a subset of them would definitely have. So how would you proceed in such a case? Srinivas, can you tell me, when a male comes with your lower urinary tract symptoms?
Usually on lower, after that we'll ask for PSA level, sir. If it is normal or abnormal, because age is of higher side, so it's better to do PSA.
Okay, and after that we'll do a biopsy if the PSA is high?
It's not always, sir.
It is not always. We don't do. Depends upon the. So okay, we'll come to that. Yes. So I'll maybe start with the picture. This was the biopsy done for the patient, yes, and I have labeled this as core 1 and core 7. So what are these cores? How many cores do we take? Vidya, can you tell me? Do you see many cores, Vidya, in your hospital? Do you see core biopsies of prostate? I think Vidya is not.
I haven't seen it.
You are there?
We received prostate chips, TURP chips, but I haven't seen chips.
TURP chips, so you don't see core biopsies. Yes. Okay. So we'll move on to the next person. Vinaya, do you see core biopsies in your setting?
No, sir. We will see chips.
Achha, so there are no core biopsies done in your place also?
No, sir.
Okay, I think we will, before we go on to the case proper, we will just discuss a couple of these things. Do you know of the zonal anatomy of the prostate?
Yes, sir. 3 zones: transitional, central, peripheral.
Okay. Priyanka, can you tell what are the zones of the prostate and where does the prostate cancer arise?
So there are 3 zones: the central, the peripheral, and the transition zone. And peripheral zone, more prostatic carcinomas are common. It arises from peripheral zone.
So you agree with this picture? So this is how the prostate is placed at the base of the bladder, and you can see that the urethra passes through the prostate, and then you have the ejaculated ducts which open into the prostatic urethra, and the prostatic glands which are around the ejaculated ducts from the central zone, and then in the periurethral zone in the upper part you have the transitional zone. Is this zonal anatomy important? Do you think it is important?
Yes. Okay.
Everybody agrees? Smriti, Rucha, you agree that this zonal anatomy of prostate is important?
Yes.
Why is it important? Snehil, can you tell where the prostate cancer arises from?
Yes, sir. The prostate cancer mostly arises from the peripheral zone.
Peripheral zone. So it's important. Very good.
Yes.
So that's important. And what happens in the transitional zone generally?
So it's pH is more common in transition.
Okay. So when you get a TURP chips, basically what they are doing is, I'll see if I can get the laser pointer. Okay. Not able to get the laser. So the transition zone is where the benign prostatic hyperplasia occurs mostly, and the TURP chips with what Vidya and Vinaya were talking about are generally taken out from this transitional zone, and this is where they obstruct the urethra, and that's why patients of LUTS, most of them turn out to be actually BPH patients. Somebody is speaking actually in the background.
I would
Gujral
request,
sir?
I would
Yes,
request the students to make sure there is no background noise. If you
I think it's Anjali. Anjali, will you please mute yourself?
Yeah.
Thank you.
Yes.
And I
So,
think if you want the right click, Santosh, can you right click?
yeah, I'll just check.
Okay, and then you'll get laser.
Yeah, pointer option. Yeah,
Yeah.
I'll just.
Okay.
So this is your transitional zone where your benign prostatic hyperplasia occurs, and generally most of the LUTS patients or lower urinary tract patients will undergo a TURP resection, where they go into the urethra and take out this part of the prostate, and you get a lot of BPH kind of tissue which you see. But mind you, this prostatic peripheral zone which develops cancer, it can impinge on these areas, and it's not very uncommon to find prostate cancer even in the TURP chips, because once they start removing these areas, they may hit these areas, and you may find prostate cancer also in the TURP chips. Dr. Verma, you want to add something on this?
Sorry. Yeah, just a little bit. I probably worth saying is that the cancers that you get in the TURP chips are different from the cancers you get in the peripheral zone. So the bulk of the cancers that are clinically significant are the ones that are from the peripheral zone, while the low-grade, low-risk tumors, the incidental are in the transition zone. So, and as Santosh said, TURP and biopsies are sampling different areas, and also the mimics of prostate cancer, which Santosh will be talking about later probably. You get different mimics in the central zone and the peripheral zone. That's why it's important. It's useful to know the differences between these two zones.
I'm not going to touch, sir. I won't reach there, I think. So
anyway, so just very briefly, things like adenosis.
Yes.
That's a central zone phenomenon, right? Or a transition zone phenomenon.
Yes.
While you get some anal vesicle change, like the ejaculatory duct in the differential diagnosis, that you're not going to see that in a TURP. That will be a needle biopsy differential diagnosis. So sometimes like nephrogenic adenoma, again, is a transition zone phenomenon. Yeah.
So I think Srinivas and Shivani, we were talking about how a LUTS patient is diagnosed. So how do we reach a diagnosis of prostate cancer in the clinics with the urologist, with the help of a pathologist? The first thing to do is a digital rectal examination. So what does the clinician do in this? Anybody knows what is digital rectal examination? Have you done during your MBBS? Nobody is saying anything. So I think this is important for the urologist. This is very important. Although this is not diagnostic, but when they put their finger, the index finger, a gloved index finger into the rectum, they would palpate the different areas of the prostate, and they will try to see if there is some anomaly in the prostate. So generally, if there is a hard nodule, they would record this. They would see whether the rectal mucosa is very smooth over there, whether the rectal mucosa appears to be involved. So digital rectal examination is a very important part of initially working up a prostate cancer, possible prostate cancer patient. And like Srinivas said, serum PSA is very important. And then if it is needed, a biopsy is done. So every patient who has LUTS does not undergo a biopsy. So you were correct in saying that every patient who is a lower urinary tract symptom may not need a biopsy. Now we'll just look at certain terms. Have you heard these terms? Serum PSA, free PSA?
Yes, sir.
You have heard, Srinivas?
Yes. Yes, sir.
Priyanka, you know about these terminologies?
Yes, sir, but not PSA density and velocity.
Yes. So they are not commonly used. I've just put it here for completion's sake. These are important. The most important one I've put it in red, that is the serum PSA level. So any elderly male who has got LUTS may get or is generally would get a serum PSA level. And if the level is between 4 to 10 nanogram or more than 4 nanogram per ml, the patient is very, very likely to be sent for a biopsy. So this is the cutoff. Everybody agrees for this?
Yes.
Yes.
So serum PSA is something which they use as a tumor marker. You understand? It's not the best tumor marker, but then it is used very, very commonly by the urologist to sort of segregate patients whom they need to do a biopsy. after biopsy, when they treat the patient, they actually treat the level of PSA level. So it is an important parameter which you should remember when working up the case of a possible prostate cancer. The other ones are the free percentage PSA levels, the PSA velocity density. I've just put in the values here from again, these vary in different organizations, different countries, different ethnicities. So these are not very sacrosanct levels, but these are sometimes used to look at a patient whom they have initially not decided to do a biopsy, but when they follow up the patient over a span of some time, they look at the change in the level of in the PSA level as per the time, and then they would use it to sort of biopsy the patient. So what is this image? Anybody? Ankita is there, or Smriti maybe. Smriti, can you tell what is this image? What does it show? It's showing the biopsy procedure of a truss guided biopsy. Okay.
Yes,
So
sir.
the biopsy gun is put in the rectum, and then the needle is fired in different zones of the prostate, and we'll see what kind of zones those are. And the biopsy is taken out, and that's how you do a prostate core biopsy or a truss guided biopsy. Now things are changing now. The truss guided biopsy is slowly getting replaced by transperineal biopsy. So patient, instead of doing a truss guided through the rectum, a patient is placed in a lithotomy position, and from the lithotomy position, a transperineal biopsy is done, because the chances of sepsis in those patients or infection are less in those patients. So what does this photograph depict? Srinivas, can you tell? It's a very self-explanatory kind of a picture.
Biopsy samples taken from different zones, central zone, peripheral, and transitional zone.
Okay, so these are different. These are template biopsy, a 6-core biopsy which used to be done earlier. Now most of the centers would do a 12-core biopsy. Now can anybody tell me, maybe Rucha is there, Rucha and Snehal, can you tell me why 12-core biopsy is done? Why don't we do just a single core biopsy? In the breast, we do only 1-core biopsy or a 2-core biopsy.
So, sir, I think in prostate, the diagnosis is given based on the cores. Like, like the patterns can be different in each core. Right?
So, supposing this was a breast tissue, you would put in one needle at one point.
Yes.
Does anybody know? Srinivas, can you tell me?
Sir, usually based on Gleason's types, there are 6 types. So which type is more prominent? From that, we'll view the higher diagnosis.
Okay, that's one of the points. Vinaya or Shivani, you want to tell me why we do 12-core, 14-core, 20-core, 24-core? Some people do 36-core in the West. And I think Verma sir and Borges madam will agree that we chase cancer a lot. In many
I think the record was something like 130 something cores.
No, sir, we don't see so many, sir.
Yeah, that was a record, but not in my center. That was what I was told in one of the courses.
Fine. So I think what we need to understand that in a prostate, we generally don't have a very defined mass lesion. The second point is prostate is a multifocal cancer. For that matter, even breasts are multifocal in many cases. But a dominant kind of a mass lesion is generally seen in a breast, whereas in a prostate, you don't have very well-defined lesions. And then over the year, the practice has been to take these multifocal kind of biopsies or template biopsies in the prostate. And like Srinivas also said that you may have a cancer here which finally becomes a Gleason 3, but a tumor at this apex may be a Gleason 4, a grade group 4 or a higher grade cancer. So what we are trying to find, the highest grade of the cancer. We are also trying to sample knowing the fact that this is completely and purely an empirical procedure. So this view can tell you the picture very nicely. So Srinivas and everyone, if you look at this, the red marks are the cancer and the hollow empty ones are your biopsies. And if you see in this, all the biopsies are missing all the 3 cancers here. You understand? So we have to understand one fact, that when we are sampling the prostate, we are randomly or going by a template, but that template may completely miss up small prostate cancer. Understand? The idea again to understand is that prostate cancer which we are missing may be a clinically insignificant, not a significant cancer. Because if it's a significant cancer, larger cancer, higher grade Gleason cancer, that is likely to be biopsied by this process of biopsies, which is a template biopsy which is done. You understand? So we have to keep this in mind. It's a multifocal cancer. We are trying to sample something and we may or may not hit it with the needle biopsies. Again, a picture to show that all 12 core done here. All these gray areas are the tumor and the brown are the benign prostate. And if you look at these core needles, some of them do not have cancer. Some of them will hit the cancer. You understand? Yes. That's very, very important for us to understand what we are going to talk about later. Any points on this, Verma sir, you want to add on this?
Yeah, I think it's probably worth mentioning a couple of things. Things are changing. Certainly in the West, things are changing. What changed, the problem we had in the prostate is that the abnormality was in the blood, the serum PSA. And then we were searching for the cancer with systematic biopsies in the prostate without having a clue where the cancer is. What's changing now is MRI. They've got much better MRI techniques, and they've got these, multiparametric MRIs, which are very sensitive.
Yes.
So what's happening in the West? I'm not saying that this is still some way off, but in the West, in the UK, all patients before prostate biopsy get an MR.
Yes, sir.
Right? And so now we are moving. So we get, in addition to these systematic biopsies, we get targeted biopsies.
Yes.
And there are some centers which are talking about stopping taking the systematic biopsies and only taking targeted biopsies, which makes it very much similar to the breast, where you do a mammogram and then only sample the mammographic abnormality. So we might, in a few years, be moving, prostate pathology might become more and more like breast pathology.
Yes. Borges, madam, would you agree with this slide?
I think it's 1 minute. Yeah, I think we're chasing cancer not just in the prostate. We've just gone mad. We're chasing cancer everywhere. And I don't know whether, what's going to happen soon is that there are so many of these tests that are coming up, blood tests, which purport to find cancer when it is very, very early. The question, my way of looking at it is I don't know what we are finding, number one, and number two, even if that test is very accurate, the question is, where is the cancer and how many other tests do you have to undergo to actually find that cancer? So I agree with you. We chase cancer too much.
Yes.
We've become, I think, neurotic about preventing cancer.
Yes.
But there's one thing I would like to say. Everybody thinks that a high PSA means cancer. I think Santosh should address what a high PSA actually suggests.
Yes, so I will take this opportunity to say that even with a PSA of 20, 30, a patient may not be a prostate cancer patient. In a country like India, where UTIs are very common and secondary to stones and all, your PSA may be raised in these patients. So just because the PSA is 20, 30 doesn't make him a cancer, but he is definitely likely to be a candidate whom a biopsy is likely to be done. Understand? So the clinician, especially if they are not suspecting an infection, if they're suspecting infection, they would treat the patient with a course of antibiotics and repeat the serum PSA after say 3-4 weeks. And still if the PSA is on the rising trend, then they would definitely do a PSA. So there are many under conditions where you would sort of, and the PSA may be increased, but it may not be a cancer, like granulomatous prostatitis is one. There are post-catheterized patients in whom serum PSA is raised. So there are several other conditions where PSA may be raised and it may not be cancer. But in a simple LUTS patient, an elderly patient with a serum PSA of 4 to 10, a urologist would generally prefer to do a prostate biopsy, especially if the MPRM-MRI, like Dr. Verma has pointed out, also shows some some issues with the MPMRI. I will not go into the details because we are dealing with PG students here.
Yeah, I think.
Santosh, can I make one point?
Yes, yes,
oh,
sure.
sorry, carry on, Murali.
No, after you.
So what I was saying is that just a very large prostate itself can raise PSAs, and quite often when you have obstructive uropathy because of a large prostate, you will inevitably find that the PSA is high. And that's why they have this issue of density. You know, what is the amount of PSA per the amount of prostate? I don't know, Murli, maybe you wanted to
I
say.
think I was going to make probably practically the same point. I mean, the point is that PSA is not cancer specific. It is produced by both the benign prostate and the malignant prostate. It's just that the malignant prostate produces more, and because the architecture is lost, that PSA goes into the blood. So any large prostate gland, the patient would have a raised PSA. And as the patient gets older, the prostate gland starts becoming bigger, the PSA levels will go up. So which is why we look at the rate of increase. So the PSA
that's why the velocity and
rapidly,
density becomes increased.
that is PSA velocity. And the PSA with respect to the size of the gland, that is PSA density. So those are the ways we try and identify patients which are significant.
Yes. So this is how the 12 cores will come in 12 different bottles, and they are labeled like this: right upper outer quadrant, right middle outer quadrant, right lower outer, similarly right middle inner. So this is how they are labeled and they will be sent. Now this is a core biopsy in its entirety. Everybody can see this?
Yes.
Nehal, Srinivas? Yes. So what do you look in a prostate core biopsy in low power? What are you trying to find out if you are looking for a cancer? So this is how a core looks like. Let me go to some higher power. Do you think it's benign or malignant?
It looks like benign.
So what is the basic histology of a prostate gland? It's a glandular, it's a fibro, and it's a muscular. So this is your muscle, this is your fibrous tissue or the fibro glandular tissue, and then you have the glandular tissue here. You understand? So is it benign or malignant? How do you decide on that? Can maybe Priyanka tell me? Priyanka and Smriti? Is this
Yes, sir.
benign or malignant?
Sir, I think this is a benign conditions.
Benign condition or benign gland? What do you want to say?
Benign gland.
Benign gland. Why do you say it is benign? Why do you say it benign?
Sir, in benign gland, there is a presence of basal layer.
Okay, you can make out the basal layer.
Sir, in high power.
High power you would be able to say. Okay.
Yes, sir.
What
in
is
high
the subtle feature on low power which helps you tell that these are benign glands? So even at the low power, it is very, very important to look at the architecture of the glands. You understand?
So architectures.
Yeah. So these are generally what we call as large glands. You understand? They are all together. You understand? And
yes, sir.
Look at the lumen of the glands. They are very undulating lumens. You see the stellate kind of lumen? Stellate undulating lumens. So most of these stellate undulating large glands would be benign glands. Look at the cell morphology. They have got a clear to foamy kind of cytoplasm, moderate to abundant cytoplasm. These are your luminal cells which are very nicely seen in this glands. You understand? So at low power, you are looking at the stellate lumen of the gland. You understand? But look at this gland. This is little different from this gland. You agree? Everybody agrees that this gland and this gland don't look similar?
Yes, sir.
The luminal cells are almost very, very atrophic in this. You see this? The luminal glands are not seen. What you see is very blue looking glands. And when you see these blue looking glands and stellate lumen, you're probably dealing with an atrophic kind of a pattern. Although atrophic glands can be very small, they can be very rigid. But this is early kind of atrophy where the luminal glands are not seen. Here you see the luminal cells are very nicely seen here, and the lumen is very stellate. Again, is this benign or malignant? Can Vidya or Binaya comment on this? Is this gland, these glands?
Benign, sir.
Benign. Because again, they are large glands. They have got a stellate lumen. They have got luminal cells and maybe basal cells. But mind you, very, very careful. If you are trying very hard to look for luminal and basal, in every case and every core, you might find it very difficult to identify the basal cells on morphology sometimes. So please don't get foxed by the fact that you are seeing some basal cells. Sometimes basal cells may be subtle. Sometimes the myofibrous cells or the fibroblastic cells may be very closely opposed to the glands, and they may look like basal cells. and you might mistake them for basal cells. So don't go by the fact that they are always bilayered, these glands. Okay. Again, everybody agrees these are benign glands. Large glands, stellate lumen, and maybe some bilayering at these places. You understand? You can see the luminal as well as the basal cells. More pictures to show you the benign gland. So see, they all look like families. They are all together and they are in a family. And when do you start suspecting prostate cancer? Any idea? Again, benign glands, everybody agrees?
Yes.
So when do you start suspecting prostate cancer? At low power, what are you looking for? Priyanka?
So we'll be
Sorry?
looking at the architecture of the glands, like if there is any change in the dilatation in the proper structure and the lining of the gland.
Okay. So see, this is your benign gland. You can again see bilayering maybe here. The first sign which at least I look when I look at a core biopsy is to look for small rigid lumen glands which are infiltrating between the large benign looking glands. You understand? Small rigid gland. You see this gland, you see this gland, you see this gland, you see this gland. At low power itself, if you start seeing such glands, please start looking at those glands at higher power. Okay? That's when you really, yeah, Verma sir, please.
Can I just make one point at this, because this shows nicely on this slide of yours.
This one,
so
sir?
Another very, even on this one. So another very useful way of picking up cancer in very low power is to look at what is inside the lumen of those glands.
Yes.
So the benign glands are generally empty or might have some very loose secretions. While with cancer glands, they often have dense secretions within them. So, Santosh, if you quickly go through your low power of your benign glands, it's just the previous ones, right? So you can see that all these glands are empty, right? Now, if you go into your one which has both, like again, all these lumina have got empty or very thin granular material. So if you go into the last slide now, the one that has both cancer and benign, you can see the small glands. Like I can't use a pointer, but some of them you can see the thick secretions in them. Right? While the benign glands are empty. Now, this is not specific. Okay, benign glands can also have thicker secretions, but it's very useful for screening. So because you can see it at very, very low power. So that's one of the things you look at for. So it's one of the tips.
Yeah. So how do you confirm a focus which is suspicious? Snehil? What will you do? You will ask a colleague. Will you do deeper cuts? Do you do IHCs?
IHCs.
IHCs?
IHCs.
Deeper cuts? Deeper cuts? So I think it's generally a good practice always to do deeper cuts for a prostate. It's a standard practice in most of the centers that, in fact, most of the centers would supply deeper cuts along with the main sections, especially if they're lengthy and good sections. So that's important for you to know that it is not very uncommon and it's very easy to do deeper cuts to look at the focus which is suspicious. But yes, if we do an IHC, what are the IHCs which you want to do to confirm a focus of benign or malignant? Would you do only an Amakar?
P53, we can use the P53.
P53, P63?
P63.
And we can
What does it highlight?
It will highlight basal cells.
Basal cells. Do you know of any other basal cells? Basal cell markers?
We can also do a high molecular weight cytokeratin.
Okay. Smriti, you know of any basal markers which you do at your center in Nepal?
Sorry, in our center there is not done.
Okay.
But in Nepal, MCAR.
AMCAR. Do you want to do only AMCAR? Anybody who says and agrees that only AMCAR should be done?
Sure.
Srinivas, you are okay to call if you have only one IHC in your armamentarium, which would you want to have?
P63 along with AMCAR.
P60 along. I'm giving you only one option. You have only some limited money. What do you want to buy? Somebody is saying pin 4. Very nice. Anybody? So I think the point of showing you this is, please do not do only AMCAR. MCR is a very dangerous marker. MCR can come in benign glands, it can come in partial atrophy, it can come in a whole lot of different patterns in the prostate. And doing only MCR can lead you to a misdiagnosis of prostate cancer. If you have the choice, you should have basal markers. You understand? Basal markers, and the absence of basal markers is more important than MCR positivity. You understand? Anybody has any doubt on this? Verma sir is very, very strong proponent of not using MCR. I don't think you use MCR.
Yes, I'm afraid I hardly ever use MCR. I think because the problem with MCR, at one point, Sandra, I think it's important for the trainees, even from year one, to understand that the diagnosis is HNA.
Yes.
And immuno is to confirm your diagnosis. So your diagnosis is never made on immuno. It's an HNA diagnosis supported by immuno.
Yes.
And the immuno choice depends on the morphological differential diagnosis. So you look at those glands and you don't think that, is this prostate cancer? And I'm going to do basal markers and racemase. You think of, if it's not prostate cancer, what is it? What's your differential? So if your differential is between PIN and cancer, MCR is a waste of time, because almost every case of PIN will be positive for MCR. If your differential diagnosis is adenosis versus prostate cancer, then about 30%, depending on which paper you read, up to 30% of adenosis will be positive for MCR. So that's where you've got to be very, same way, if it's nephrogenic adenoma versus cancer, about 50% of nephrogenic adenomas will be MCR positive. So you've got to be very careful if you're using MCR. There are other experts who use MCR. I'm very reluctant to use MCR. I'd much rather use two basal markers, because we're looking for a negative marker. So unlike other organs where you're looking for a positive marker, here you're looking for negativity, which makes a diagnosis of cancer. And that negativity may be a technical issue. Right? So it may be a false negative. So my preference is to use a high molecular weight cytokeratin and a P63. So if I'm sufficiently suspicious about a focus that I want to do immunohistochemistry, I would do both P63 and usually now in my center CK5 and 6. But you could do any other high molecular weight.
Yes. So Shivani, can you tell me where is the cancer in this? Is this the cancer or is this the cancer?
The lower
one? You agree? So these are your glands, which are very small, rigid lumen. They look very suspicious on morphology if you had an HNE. And then you do a P63 or a P40, which is a basal marker, to show the absence of basal marker in the suspicious focus. And it is always good to take a slide where you have a control if you have. So this is internal control, a benign gland where you have the basal marker as control. The same thing applies here for high molecular weight keratin. You can see the benign gland here with this high molecular weight basal cell positivity, whereas the malignant focus is completely devoid. Now mind you, it should be completely devoid. You cannot have sort of a single kind of a very clear-cut marker. And you have to also look at the morphology of the cells, how they compare with the benign looking gland which it is adjacent to. Now this might get too complicated sometimes, but morphology, like Verma sir pointed out, morphology is the first suspicion. You have to be suspicious on morphology, and IHC is an ancillary technique, and you should have basal markers more important than the MCR positivity. And MCR, if you do, it should be strong, granular and circumferential. So the complete circumference of the suspected malignant gland should be strong, granular kind of positivity should be seen. You understand? So if it is only focal, say here or here, that may not be a very valid MCR positivity to take. The whole focus as a whole should take up the stain. All the glands should be circumferentially stained, and it should be a granular kind of a staining, which is called as a true positivity for MCR. And that's why it has got some technical issues. And many a times MCR can also be positive in benign glands and atrophic patterns, atrophies, partial atrophy, post-atrophic hyperplasia. All those can be MCR positive. So it is important not to do only MCR staining. Understood? And agreed?
Yes.
Okay. So I think again, I will go back to the picture again. So is this cancer or not? The first case? Was it a hyperplasia?
I think hyperplasia, sir.
Hyperplasia. Okay. If somebody thinks it's hyperplasia, who thinks it is cancer? Shivani, you think it's cancer?
It's hyperplasia.
Hyperplasia. You think it is hyperplasia. Why do you think it's hyperplasia? Are the lumen of the glands rigid or undulating? Stellate lumen?
No, sir, not stellate.
Not stellate. They are rigid, but they are little longer, longish looking glands. They are cut in a different plane. They may not look very rounded. Understand? You see, this is looking rounded, this is looking rounded, rigid, but they are very closely packed together.
Yes.
And if you are really looking for bilayering, you don't see bilayering here. Although I will never tell you to look at bilayering and look very carefully for any bilayering, because I don't believe we can actually make out bilayering very nicely. So this is a branch looking gland. So supposing you have 9 of you don't agree to it, what IHCs will you do for this to confirm this?
P63.
P63 or P40? Or yes, we can use P40 instead of P63. In fact, I use only P40 these days. I find P40 better than P63 for a strange reason. I don't know. I don't know the reason. Maybe the antibody clones are better. So this is how. So this is a cancerous focus, and if you do a P40 in HMWCK, this will be completely negative, and AMACAR should be positive. Like I said, circumferential in the whole focus, it should be positive. What about this core number 7? Is it cancer, not cancer? Do you see any hyperplastic process like this ever? Is this even forming a gland? No. Is this even forming a gland here? No. They're not forming a gland only, no? They are very poorly formed kind of glands here. Whereas there are very nice glands here. You see this?
Yes, sir.
And how is their lumen? Rigid, small glands?
Rigid and small, little secretions.
Yes. So you agree that this is cancer?
Yes, sir.
This would be cancer. Yes, Verma sir, please.
Yeah, I think one other point which is seen in this slide is, again, it's not specific, but the cytoplasm of the cancer glands are darker than the benign glands. So what we call amphophilia, right? So when you see that darker cytoplasm, now this will vary depending on the strain in your department. So what you do is you look in your core and you identify the benign gland first. And then if you're seeing your suspect glands, or if you're seeing glands with darker cytoplasm, then look at those glands more carefully. Again, it's not diagnostic, but these are all things that make you look at those glands with a little more suspicion and higher power.
So I'll go back to and proceed with the presentation. So I'll just ask you a question. What are the morphological features of prostate SNR adenocarcinoma? I think we discussed that large undulating glands are generally benign. They are not malignant. Blue looking large glands may be, again, they may be atrophic glands. They may be high grade PIN. You have to keep that in mind, but they are generally not invasive cancers. Glands with all these above 2 features with a lot of corpora amylacia. Yes. Hello. Is anybody speaking? So I think these 4 features are very, very important. Small glands between large glands, prominent nuclei when you go to high power, perineural invasion, and mucinous fibroplasia. And these are the 4 pictures, very, very classical pictures to show. And what Verma sir was saying, this blue, intraluminal blue tinge kind of mucinous material. You may have crystalloids, very bright eosinophilic and sharp rectangular kind of crystals might be present. This very tinctorial characteristic of the stroma is called mucinous fibroplasia. So when the tumor invades the prostatic stroma, the stroma acquires this kind of a property called mucinous fibroplasia, and which is almost never seen in benign foci. You understand? Sometimes you may see these in benign foci, but this feature is sort of a sine qua non of a prostate cancer. Again, perineural invasion, especially if it is circumferential, is almost never seen in benign glands. Sometimes benign glands may be opposed to new nerve bundle, but when it is circumferential, the glands are circumferentially present, then it is almost definite that it's a malignant. Prominence of nuclei is a very, very important feature. Most of the prostate cancers would have prominent nucleoli, almost to 1/3 the size of the nuclei. You might find red, orangophilic, or a red kind of a cherry red nucleoli in the prostatic cancer foci. So it's a constellation of findings which helps you diagnose prostate cancer. You understand? Small glands, rigid lumen, infiltrating between large glands, having this kind of mucin, amphophilic cytoplasm of the cells, no bilayering, presence of fibromucinous fibroplasia, nucleoli, and perineural invasion. So in a given focus, you may have to use all of these features to diagnose prostate cancer. You understand? And if all of these are present, you may not actually need any immunohistochemistry. You understand? Agreed?
Yes.
Agreed, guys? Okay?
Yes.
So we discussed about the 12 cores. So what is this representing, this figure representing? These are 12 slides with?
Gleasons.
Sorry? So I have labeled this. This is just a cartoon to make you understand that right-sided 6 cores and left-sided 6 cores are there. Some of the cores I have labeled as adeno, which is showing adenocarcinoma. And below that, I have written something which is mathematical. What is that mathematics represent?
Gleason score.
Gleason score or modified Gleason score. Okay, fine. So we will now learn about Gleason scoring. And I think Borges madam would be happy because madam always teaches this, that Sir Gleason was the first person who really very astute clinician who made these diagrams. He looked under the microscope and drew the diagrams of this prostate. This I got from the internet. And he sort of clubbed together the features, patterns of these glands, how the glands had the pattern, the malignant glandular patterns, and he placed them into different groups. And finally, he arrived at a Gleason scoring system or a Gleason grading system based on the architecture of how the malignant glands are placed, and he gave them scoring from 1 to 5. Now, this is the original one. Please do not get confused with the current Gleason or the modified Gleason scoring system. So in the original one, even the cribriform and the papillary and the fused glands were all under pattern 3, which is no more the case, and we will discuss it later. So any questions on this? You understand what is cribriform, what is papillary, complex papillary? So this is the 1966 diagram which I am showing you now. You understand? And then there were modifications in 2005, 14, 22, and then there are other papers in 2019 and 2020. I'll not go into the details. And
Sir,
what you see, yes, please.
Sir, old Gleason is based on only on low power magnification, sir. Not
Sorry,
on
which one? Which one?
Gleason's grading is only on low power, sir, not on high power. Old Gleason's.
Oh, yes, I would sort of agree with you. Even for the new Gleasons, also we say that pattern 4, you have to look at pattern 4 at low power, it should look like pattern 4. That's what they say. But we do end up seeing them more closely always. So if you look at this, the right side one is the current one which we use, which is the modified Gleason scoring system. You understand? So more or less 1 and 2 remain the same. If you look at the diagram from 1966, compare it with the 2004 or the 14 one. What has changed is the cribriform, complex papillary, all that have moved into the pattern 4. You understand? And what is left in the pattern 3 is a very crisp and separated out glandular pattern in which the glands are separated. You can draw glands around each of these glands. As long as you can draw lines around each of these malignant glands, they are all in a pattern 3. You understand? Even if they are very small also. Understand? Somebody is having echo, I think. So this is a picture from one of the articles of Epstein. And if you look at it, this is how all the pattern 3 can look like. And if you look at all these pictures in the above panel, you find that each of these glands are very sharply demarcated, and you can draw a line around each of these malignant glands. So as long as you can draw a line around each of these malignant glands and they are separated out from each other, they all belong to pattern 3. Once they start fusing, once they start forming cribriform pattern like this, and once they have become very poorly formed glands, fused pattern, they all are in pattern 4. Okay?
Yes.
And once they are in solid sheets without any lumen, single glands, comedonecrosis pattern, they are all pattern 5. Okay?
Yes.
This is important because now we are going to look at some cases where you're going to give me the Gleason scoring. Okay? So this is what I was just talking about. Separate glands, non-fused glands are pattern 3. Fused glands, poorly formed, are cribriform, are grade 4 or pattern 4. And single cells, Indian file pattern, comedonecrosis, solid, no gland formations, pattern 5. And how do you score Gleason scoring?
Most predominant.
So let me ask a question. Snehal, can you tell me what is this score? So this score is showing 60% pattern 3, 25% pattern 4 and 15% pattern 5. What will be the Gleason scoring? As per what I have written here, most predominant and the highest grade pattern.
3 plus 4, 7.
3 plus 4.
3 plus 4. Who said 3 plus 4? So you're not wrong. I'll not say you're wrong. Understand? So in the original 1966 Gleason, they would add up the predominant pattern and the second most common pattern. You understand? But after 2005 and based on a lot of studies and evidence, they have now realized that even if the pattern 5 is the least common pattern, even if it is less than 5% pattern supposing, you will have to put it in the modified Gleason scoring. So that is the modified Gleason. Understand?
Yes, sir.
Yes.
So Binaya, you understand what is this? Somebody said 3 plus 4, okay? Binaya is there? Nehil is there?
Yes, sir.
Yes.
Nehil, you understand? Somebody said
Yes,
3
sir.
plus 4, that was the original Gleason, but with the... Yes, Verma sir, please.
Just to emphasize that this rule is only for needle biopsies,
Yes.
not for prostatectomies. Right?
Yes, yes.
So, and the reason we do that is because in the original Gleason grading system, and Gleason didn't have any needle biopsies. Okay, so Gleason's grading system was based on largely on TURP specimens and a few prostatectomies, not radical prostatectomies, but simple prostatectomies. But when we have biopsies, the patient might have a lot of pattern 5 in the prostate, but only a little bit of that may be sampled in the biopsy. So which is why in a biopsy, we say that even if you see a small amount of higher grade pattern, we include it in the score because there may be more of it in the prostate gland unsampled.
Yeah. So, Srinivas, can you tell me this is a different core in which you have 96-97% pattern 4 and very less pattern 3. What would you score this as?
4 plus 4, sir. 8.
4 plus 4. 8. So original Gleason would have still called it 4 plus 3 as long as there was recognizable 3 and recognizable 4. But in the modified ISUP Gleason, you would disregard the lower grade pattern if the lower grade is less than 5%. So mind you, if this 5% or less than 5% was pattern 5, you would have still called it 4 plus 5. But make sure that you are 100% sure that this is pattern 3 or pattern 5 or whatever it is. You understand? So that becomes the problematic issue when we are doing Gleason scoring. Now I'll come to some practical points later. This is what the theory mentions. We'll come to the practicality. So when you have different Gleason score in different separate containers, you would score them differently. But studies have shown, and for the clinical management, the clinician will take the maximum Gleason score for that. So we'll take some examples. Okay. Okay. So you have right cores which are score 6, and then there are some scores which are 6. What would you call it? We will come to grade group little later. What would be the bottom line? The bottom line would be a modified Gleason score of 3 plus 3, 6. Fine. Agreed?
Yes.
We have another patient. Yes, this is another patient. Somebody needs to mute. Yeah. So we have these 12 cores. All of the cores are involved. You see this?
Yes.
Look at this carefully. What will be your maximum Gleason score in this?
8.
So when you write your report and you look at the patterns, you will put each course, you will score it separately in your report. But in the bottom line, it is preferable that you mention the Gleason score 3 plus 5, 8, which is the maximum score in this. You understand?
Yes, sir.
Yes, sir.
Another one. What about this one? Vidya. What would be a bottom line Gleason scoring? You have different Gleason scores in different cores. But what would your bottom line score?
8, sir.
8. You are sure? Because 8 is the maximum you see in, and there are 3-4 cores which are 4 plus 4, 8. Fine. What about this one? There are a couple of cores which do not have any tumor. Some have very little very low grade tumor like 3 plus 3 6.
5
Just
5 plus
5
4
plus
9.
4 9. Okay. So this is how you report when you have 12 cores separately put on 12 different slides, and all cores are scored differently, but the bottom line you have to give the highest or the maximum score. I don't know, Verma sir, are you giving global score or maximum score, sir?
Right. Okay. So this is getting into major controversy now. Okay.
I know. I think
so
we can.
you've got different approaches. Yes. So the Americans tend to give a separate Gleason score on each core. And partly that's got to do with, that it may be a separate higher grade tumor. But partly it's also got to do with billing and reimbursement. Okay, so that is a totally different ballgame, nothing to do with medicine. It's about how the pathologist gets money from from Medicare and Medicaid. So that's a different issue. But the point I'm making here, so what we do is slightly different. If you give like this, so suppose, let me give you an example. You got a lot of cores with 3 plus 4 equals 7. And one core has got only pattern 4, which is morphologically identical to the 3 plus 4, the pattern 4 in the 3 plus 4. So that patient is almost likely to have a 3 plus 4 tumor where one core just happened to hit only the pattern 4.
Yes.
So if you label that as 4 plus 4,
yes,
you're almost certainly going to overtreat the patient. So you need, so at the very least, if you're going to give a separate score like this, that's fine, right? But in those cases, do add a comment that this might not be representative. Otherwise, you will end up overgrading.
Yes.
But for us, we do the reverse. We give a global score for every case. And if we think there is that these are 2 tumors, then we raise the possibility that this might be a separate higher grade tumor. So it's 2 different ways of doing it.
Yes. So, Snehal, are you there?
Yes, sir.
Snehal, what do you see? This is cancer or no cancer? This one and this higher power of the same focus? You think it is cancer?
Yes, sir.
You think it's cancer?
Yes, sir.
You see here, this is very nice benign gland. You see this? They've got a lot of cytoplasm, they've got bilayering, and in comparison, these smaller glands are rigid. They've got some mucin, they've got amphiphilic cytoplasm, they've got this blue tinge mucin, and they are looking there as if they are not bilayered. So this is cancer, and what would be the Gleason for this? These are separated out of glands. Some look a little fused, but look at them, they are actually not fused, they are close together. They are not fused glands. Okay? So again, the same picture to show that this is again a Gleason 3 plus 3 6, not exactly 4 here. I would not call it 4. These are some branched glands here, but they are exactly not very fused glands here. In comparison, look at this picture. Srinivas, what would you think this is? Do you think there is some fusion here?
Yes, sir. Yeah.
Yeah. So there is some degree of fusion at least here and here. So there is some pattern 4 in this, but most of them are again pattern 3, and then there is some 4s here. So this would probably be a 3 plus 4 7 and grade 2. Again, the same picture to show that there are very nicely rounded rigid glands where you can draw a line around each malignant gland. These are pattern 3, but at the lower end of the picture here, can you draw a line around these glands?
No, sir.
No, so you cannot draw. These are not separate. They are fused glands. Early fusion of glands is occurring. So there is some pattern 4 here, definitely. What about these glomerular glands? They look like glomerulus?
Yes.
Yes, sir.
So if you look at these glands, you can probably draw a line around each. But when you see this glomerular appearance of the glands with some cribriform punched out holes in this central glomerulus kind of appearance, they are almost always graded as on pattern 4. And if this is the only pattern, they will give a score of 4 plus 4, 8 in this. What about these ones? What is this pattern?
Cords.
Cords, chromosome. Is there any single cells? Single cells, corded pattern. You can see the prominent nucleoli. See this?
Yes, sir.
Yes,
This is cancerous focus. What can this be mistaken as? If you see single cells, and supposing the nucleoli is not so prominent, you may mistake them for lymphocytes. Okay, you always keep that in mind. This is a very, very crushed focus. You understand? It can sometimes an inflammatory focus can look very crushed, but here you can see perineural invasion. You see this nerve bundle here? Like I said, circumferential perineural is generally would be a cancer and not a benign condition, and that's very important to again. So this at low power, if you look at low power, this is little higher power, but at low power, these may look like lymphocytes. You understand?
Yes.
There is absolutely no gland formation. But even in this power, you can make out that the nuclei are little larger than the lymphocytes. You understand? They are little larger. There is nucleomegaly. And obviously, if you go to higher power, you might to look for nucleoli, you look for the cytoplasmic characteristics. You may try and find some acinar pattern in this. But in general, you have to be careful not to miss a completely 5 pattern and not label them as lymphocytes. Okay. We have had seen cases where people have mistaken. Verma sir, you would agree with that?
Yes, entirely.
So I think this is what we saw some cases. I think before we go into this, I'll show some cases. So this was case number 2, 75-year-old gentleman Lutz and say raised PSA. So this was core 3. So any one of you can say Ankita is there?
Okay.
Sorry, my WhatsApp is again shut. Let me open it up. I am forgetting the names.
So here we can see some hyperchromatic cells.
Okay, here.
In the muscles.
Gods. In gods.
In the right.
Single cells, gods.
And we can see foci of necrosis also in the upper corner, just below that foci.
This is not necrosis. This one? Is this necrosis? No, this is all muscle. I don't see any necrosis in this. Yeah, so I will ask Rucha and Smriti also to comment. Do you think there are any gland formations here?
No, sir.
I think first it is cancer or not?
It is cancer.
It is cancer. So you see all these single cells look like cancer to you?
Yes,
possibly. Okay, possibly.
Yes, sir.
My point is not to see. You have to obviously look at your own slide when you come across that. But when you see such focus, please go to higher power. Look at them more carefully. What about this one? This is core 5 from the same patient, supposing. Again, solid sheets.
Yes.
No lumen. Yeah, Verma sir, please.
Yeah, just one point on the previous slide. You know, when you this one here. So when you see something like this, where the cells have got very dark nuclei and they've got very scant cytoplasm, before you give a Gleason score, check whether the patient's already received treatment. So if he's got, sometimes they start hormones before, if he's got clinically obvious cancer and they start hormones, and this can all be hormonal effect, in which case you'll end up overgrading the patient. Okay. So with typically post hormones, when they do a biopsy, you get very atrophic glands, very scant cytoplasm, and the nuclei become very dense, dense lymphocyte-like nuclei. So when you see this appearance, so if I was doing this in my practice, I would start suspecting that this patient might have had hormones.
Yes. Again, this one, Vidya and Vinaya. Vidya and Vinaya, please tell me what do you think of this?
So we can see states of cells and mucinous fibroplasia also, I think.
You think this is mucinous fibril? No, actually, this is not exactly mucinous fibril. It's got little different tinctorial characteristic. That's a good try. Not a problem. At least
you present in single and in seat and gland formation.
No gland formation, no cribriforming, forming, sheeting pattern. So this is a very poorly differentiated foci. You understand? Now I am showing you this score just to sound you one more thing. When you see kind of sheeting pattern, poorly differentiated pattern, no glands pattern, no papillary pattern, no acinar pattern, please always keep in mind that it can also be a urothelial carcinoma. Understand? Always keep that in mind. In the back of your mind, you should always think that there is no gland, no cribriforming, no acini. How do I call it a prostate cancer first? Can it be a urothelial carcinoma? Please always think about it. Okay? Because the management of a prostate cancer and a bladder cancer are poles apart. Yes, Verma sir, please.
I think you're absolutely right. Okay, so it's very important to distinguish urothelial from high-grade prostate cancer. Otherwise, the patient could get an unnecessary cystectomy if you misdiagnose it as urothelial. But the other one you have to be careful about when you see something like this is small cell carcinoma.
Yes.
Again, very dark, very little cytoplasm, no acinar formation. Think about small cell carcinoma again because the treatment is going to be very different.
Yes. So anybody knows what IHC would you use to distinguish a urothelial from a prostate? Anybody who's doing Snehil or Shivani maybe? Shivani, are you doing IHC?
No, sir, I don't know.
So Apurva has said Paxate. I think Paxate doesn't come in urothelial, neither does it come in prostate generally. So GATA3 is a marker for urothelial. Again, not all will come positive, so you may like to do a panel. Remember, prostate cancer do not express CK56, HMWCK, P40, but a urothelial will generally express some of these markers like P40, CK56 and HMWCK. So a panel of GATA3, HMWCK and prostatic markers like NKX and PSA-IHC will help you distinguish a prostate from a urothelial. Now, I'm not showing you too many IHCs. The idea to convey to you is that when you see sheeting pattern, when you don't see glands, acini, cribriform, and you see a very poorly differentiated core biopsy of a prostate, always think and put it in your back of mind not to miss a urothelial cancer. Okay? Am I clear about that?
Yes, sir.
Case 3 quickly again. This is so there are many cores with this pattern. What is this pattern? You would agree this is kind of a anybody who wants to Priyanka?
Which case, sir?
Sorry?
Sir,
is this
case
cancer or not cancer? First and foremost, is it cancer?
So yeah, it's malignant.
It's malignant. Everybody agrees?
Yes.
Yes.
You see, for comparison, you always have a benign gland. Always start looking from a very clear benign gland. You will then look at the other focus and it will look completely different from a benign gland. You understand? And this is the nice punched out holes and it's showing a cribriform kind of a pattern, which is very nicely seen in this. Again, cribriforming pattern. You agree? Everybody agrees?
Yes, sir. Cribriform pattern.
Yeah. So what would be, supposing the core has only this kind of glands, what will be your Gleason's scoring?
4 plus 4.
4 plus 4. Very good. Very good. Very good. 4 plus 4, 8 would be your Gleason. Very good. Case number 4. So different presentation. 55-year-old male patient with bone pains. Why does this patient have bone pains? Can anybody tell me why patient will present with bone pains? Metastasis. So prostate cancer is a cancer which commonly metastasis to the bones. What kind of metastasis are there in the bones? This is osteoblastic, lytic, blastic. So people are typing in the report, blastic. Ujjwal says it's blastic. So most of the time is osteoblastic metastasis. Taken out. Okay? Agreed?
Yes.
But in small cell carcinoma, it's a small cell carcinoma or a neuroendocrine transformation. Many a times there are lytic bone. Okay? So this is the core file of the patient. What do you see here? Srinivas? Benign malignant. So start with that. Is it are they benign glands, malignant glands? Malignant glands. Very good.
Malignant, sir. This is.
So you might sometimes struggle with Gleason's scoring. There is some gland which you can draw a line, you may call it 3. Fine. There are some poorly formed which will call it 4, and then you have some 5. So this is a common scenario. I'm not trying to tell you what the score is or what I may be correct, I may be wrong. I'm not telling you. The point is you will have mixtures of Gleason in many of the cores. Okay, na? You just don't go by one core, and that is what I'll come to you in a little time. When you have 12 cores, when you're looking at 12 cores, please see all the 12 cores first. Don't try doing Gleason scoring on one core, break your head, is it 3, is it 4? That's the practicality of the issue. Supposing the patient is 75, he has bone mets, his PSA is 500, your one core of 3 plus 3 or 3 plus 4 doesn't matter, or 5 plus 5 doesn't matter. You have to look at 12 cores. Okay, na? You have to look at all the 12 cores and look at the core which has got the maximum Gleason. The idea is just to pick up the maximum Gleason. If your first core is showing 5 plus 5, 10, that's it. That's the maximum Gleason. You understand? Having said that, you as a resident, you have to see all the cores. The practicality of the situation has to be taken into consideration. You are not treating a core, you are not treating a core of a prostate, you are treating a patient. Okay? Somebody has to mute again. So this is nothing but maybe there is some pattern 5, there is definitely pattern 4, some maybe pattern 3. So you have to look at the whole picture. Right? Fine?
Yes.
Again, I'll go back a little bit. So we have been talking about Gleason. There is something very, very important along with the Gleason is the percentage of the core. Now, this is a very, very controversial issue. Again, I will definitely not delve into details of this, but I'll tell you what is the practical importance of so this is the core of the tumor you see here. These are the benign glands at the bottom, but this is all a complete tumor. Understand? So if you roughly eyeball, this forms around 30-40% of the total core of the prostate. You understand? Prostatic core. So in your report, you will say 3 plus 3 6, or maybe 3 plus 4 7, whatever it is, and you will say that the tumor involves 30% of the core or 40% of the core. This is a very rough eyeballing. Verma sir, I don't know how stringent you are in the UK about percentage.
Can I ask a question to the students?
Yes.
Right. How many of you do breast biopsies? Do you measure the tumor in breast biopsies?
Somebody answer, please.
No.
You measure the...
No, you don't.
You measure the percentage of...
You don't measure the length of tumor in breast cancer. You don't measure the length of tumor in any other cancer in a biopsy. If you get a thyroid cancer biopsy, a papillary carcinoma, you don't measure the length, right? So why do you measure the extent of tumor in prostate when you don't do it in any other organ? The point I'm trying to get here is, you need to understand why we are doing things. And so when we do something strange, there is some logic behind it. And if you understand that, actually your life will get a lot easier. The reason we do that is because we are doing the clinicians have no idea what the size of the tumor is. In a breast case, he can either palpate the mass or he can see it on the mammogram. So he has got an idea what the size of the breast cancer is. In prostate, we don't. And that is why we give an idea. So the reason I'm saying this is when you got a large amount of tumor, it doesn't matter what your percentage is. The percentage only matters when you got small amount of tumor. Right? The problem with the percentage is that you got a numerator and a denominator. A 3 millimeter tumor in a 4 millimeter core is not worse than an 8 millimeter tumor in a 20 millimeter core, even though the percentage will be much higher. Okay, so I think the only thing I would say, Santosh, is don't worry too much about the percentage. Give a rough, just do an eyeball.
That's exactly what I wanted to tell them, actually.
Right. So nobody really cares too much. I think as pathologists, we worry too much about it. We could go on this, but I think it's just...
That's why I'm going back and forth in the presentation. It's a very, very kind of an informal presentation, I would say. So the question is to all the students, is Gleason grading score important?
Yes.
Does it convey anything? What does it convey? You know what it means? So this is the practical importance. You understand why are we struggling to give Gleason scoring, the percentage of tumor, percentage of pattern 4, percentage of pattern 3. You must know the clinical context and connotations. Okay. So needle biopsy is the most powerful prognosticator, the Gleason scoring in needle biopsy. Okay.
Yes.
And it helps predicting the pathological stage, the extraprostatic extension, lymph node metastasis, seminal. So there are nomograms. Nomogram means there are several charts or kind of there are several, what do you call, pointers. There are point-based systems. Depending on the pattern 4, the number of Gleason cores involved, the length of cores involved, the PSA level, they can help all predicting these for a patient of prostate cancer. And that's why needle core Gleason score is a very important prognosticator. And as pathologists or budding pathologists, you also need to know what are the therapeutic options. How are prostate cancer treated? Anybody knows? Shivani, Smriti, anybody can tell? You have the picture in front of you.
Yes. We can give radiotherapy, hormonal therapy.
Very good.
And surgery can be done.
Very good. So they are all done for different tumors. You understand? Prostate, if the cancer is confined to the prostate, it is a Gleason 6, 7 or early 8 cancer, you can do a prostatectomy. If the tumor has already spread to the nodes, probably you would give hormone plus radiation. But what is this active surveillance? Anybody knows what is active surveillance?
It's like after 5 years, how much was the patient was like?
No, what do you mean by active surveillance? So some patients are placed on active surveillance. Followed up, yes. No treatment, regular follow-up. Maitri says it's no treatment, regular follow-up. So it's not actually just following, we are actively following up the patient. In the sense, if the PSA rises or if you think that the grade of the tumor is increasing or something, you need to do, yes, PSA velocity or holistic during active surveillance. So Srinivas or Vidya, anybody can you tell me why I'm showing you this picture? How is it related to pathology and Gleason scoring?
So, hormone therapy and radiation therapy, this might change the architecture of the cells and architecture of
Might
the
change
gland.
the treatment. That's very nice of you to say that. So once you give a radiation hormone and then you do a core biopsy, you may find a completely different what Dr. Verma was showing on that picture. Okay, you may have single cells and you may not be able to give a Gleason gradient. But supposing this is upfront, you have a core biopsy, you have given a Gleason, does it affect the clinician to choose one of these treatments? Do you know that? So I'll come to that. So that's what I wanted to show you here. This slide. So this is the most important slide in the whole presentation, especially when you're looking at core biopsies. So be very, very careful if you're reporting 2 or less cores positive as positive. So you're sure you have a cancer, but only 2 of the cores are positive. Be sure your Gleason scoring is accurate, because pattern 3 versus pattern 4, once there is clearly pattern 4 or a cribriform pattern 4, then those patients may not be placed in active surveillance. Although there is a move now that even little tumor in 2 cores, even if there's some pattern 4, they may go for active surveillance. But if it is a pure pattern 3 in 2 cores and your Gleason score is 6 in 2 cores, that patient may be spared any kind of treatment and put on active surveillance. Again, if you are reporting 2 cores positive, less than 2 cores positive, make sure your percentage core is involved. That's what Verma sir was saying now, that it is only at the lower end of the spectrum. So you understand, you have only 1 or 2 cores positive, it's a very low grade cancer, pattern 6, pattern 3 cancer. That's when your percentage matters. Yes, Verma sir, please.
Yeah, just to make a point, again, I think it is important that, this thing about this 50% cutoff and surveillance. So this was part of the Epstein criteria for active surveillance.
Yes.
Right? But even Hopkins have got rid of that. They no longer use it because
nobody uses it.
As I said, 50% of a 3 millimeter core is very different from 50% of a 20 millimeter core. So even Hopkins do not use a percentage of the for active surveillance anymore. So again, take this with a pinch of salt. Do it, report it if that is your protocol. But you'll find that very often talk to your clinic. I think the most important thing, if you can, and I know it's not easy in every center, is to talk to your clinicians. Talk to your urologist. So if you're not, obviously as a trainee, you're not in that situation, but what you're doing as a trainee is training to become a consultant, right? And train.
Yes. So this is what I was talking about. You only got 2 cores positive and both the cores are 3 plus 3 is 6. In this situation, you have to be very sure that it is a 3 plus 3 is 6. In this situation, you have to be very careful of your percentage. Rest, if you have 10 cores positive, 12 cores positive with a Gleason of 4 plus 5, 9, I don't think the percentages matter. I don't think the percentage of 4 or 5 matter in those cases. So it is at the lower end of the spectrum of Gleason reporting where the percentages and the Gleason matter. Yes. Great. Any questions? Moderators, any questions in the box? Somebody has to mute again.
আজি আপোনাৰ ডায়ালাইসিস হৈছে ডায়ালাইসিসৰ আগতে ক্ৰিয়েটিনিনটো 74 আছিল আৰু মোৰ
Somebody has to mute.
I don't think we could hear what the lady was saying. Can you just put your question in the chat box, please?
Borjese madam, you would like to add something?
No, except to say that it's easy to just talk about 3 plus 3 and
of course,
or whatever.
Totally.
But it's age. It is, whether this patient has got a family history of prostate cancer. There are so many other.
Of course, to decide on therapy. Yes.
That, it's not just looking at the the grade of the prostate cancer, or for that matter, how many?
Totally, man.
Yeah, what is the
If it's a
percentage?
90-year-old and he has got a very low grade, there is no need for
I
treatment.
think even if he's got a 3+4, what do you want?
Yeah, nothing, man.
Yeah, you and for that matter, I even a 4+3. I just wouldn't worry with this man. No, so it is a lot of factors.
Yes.
That,
So
that you have
therapeutic
to
decisions take a lot of things into consideration. It's not only obviously in a country like India, it's always a lot also financial things which are. Yes, Verma sir, please.
Yeah, the other point is I think clinicians in all organs, not just in prostate, they don't look at individual path findings, right? So they usually put the patient into low risk, intermediate risk, high risk.
Yes.
So in most tumors, there are three. There may be four. There's 3 or 4 categories. Now this is relevant. So if your finding is going to move the patient from one category to another category, then it becomes more important. So they don't have a way of using every single one of your data that you produce. So, and very often if a patient is in the highest risk category, then whatever else you report is not going to change it. So you don't have to fuss. So it's a case of where you need to worry about things and where you don't need to worry about things.
So I think another thing which has come up in the recent last maybe decade or so, I can say is that somebody is speaking and somebody needs to mute, I think.
Almost 60
Vidyapati, can you mute yourself, please, because somebody is talking.
Yes. So something which has again come up in the last decade is the understanding that somewhere in the prostate, the patient has to have a pattern for to develop a metastasis. Now this has come from a lot of studies from John Hopkins and all, where they have studied 14,000 prostatectomies, and they found that a pure Gleason 6 has almost a 0% chance of metastasizing. So the corollary to this would be, or the flip side of that would be that should we call it a 3+3 as a cancer? And it also tells us that somewhere pattern 4 has to be present to develop a metastatic position. And then the whole crux of the issue has now started revolving along this fact. Something again which has come up is that Srinivas and Snehal, if you understand that Gleason total scoring can go from 2 to 10, the Gleason scoring, but 6 is the minimum cancer which we can diagnose on a core biopsy. So you can see that a grade 1 and pattern 1 and 2 you cannot diagnose on a core biopsy because you cannot see the circumscription of the tumor core. You understand?
Yes.
To see the circumscription, either you have to have a prostatectomy or you have to have a nodule, a clear-cut tumor nodule, very circumscribed in a TURP chip. In a core biopsy which is going through the tumor core, we will never find the circumscription. So the minimum score on a core biopsy which you can give on a core is a 6. Now 6 places the patient on this spectrum of 2 to 10 in the middle of the spectrum. Understand?
Yes.
So what the patient feels is, I have got a 6 out of 10 Gleason cancer and I will die in some time if I don't get treated. But actually in practicality, this is the minimum cancer which can be diagnosed. You understand? Everybody understand this fact?
Yes.
Okay? You cannot diagnose a Gleason score 5 or Gleason score 4 on a core biopsy. So the understanding in last decade has been that 6 is the minimum cancer which can be diagnosed, and 6 may not need to be treated unless it is very substantial amount of 6 cancer. You understand? So prostatectomy for early cancers is done, but if the cancer is present in a couple of cores or 3 cores, like Borges Madam said, we may not need to treat those cancer patients. And that is why we have come up, or the grading system has been changed to this new Gleason grading system, or the grade group system, in which they have placed Gleason score 6 as a first group or the grade group 1. Now this is not for fun, this is actually a prognostic grade group. You understand? So they have plotted all these progression-free survival graphs and found that Gleason 6 cancer has got very good outcome, and that's why the patient needs to be told that you are in a group 1 prognostic group. You have got the best prognosis and you may not need treatment. Okay? Yes. The same way they have found out that if the patient has got a lot of 4 in the core, say 80% 4 and 20% 3, that would fare worse than a patient who has 80% 3 and 20% 4. So they have split up this into 2 groups as grade group 2 and grade group 3. And similarly, all totals which come up to 8 are put in grade group 4, and all Gleason 9 inter are grade group 5. Fine. So this is your 12 course, and this is again the same thing which I said, and this is the thing. Okay.
Sir, there are 2 questions in chat box.
Please, yes, carry on.
Please explain the PSA velocity.
PSA velocity is over a time period of 1 year. They would measure, I think, 3 times during a period of 1 year, and then they have a complex analysis of that. I think there is some statistical method, and to find out the velocity of PSA, and then there are cutoffs in different regions for different races. So it's not a very clear-cut thing, and we don't generally use in the clinics too much. I don't know, Dr. Verma, maybe at your center you may use VPSA velocity more than ours.
Yeah, I think the PSA velocity is basically the numerator is a PSA change and the denominator is time. So the rate of change of PSA, that is all it is. So if it is changing rapidly, that's more likely to be clinically significant. On the other hand, if it is something that the PSA is rising very slowly, that may be just a benign gland getting bigger with more BPH.
So I'll just move on to the last case. This is a 72-year-old patient with PSA of 25. So this is a scan case. You can see that this is the scanner image. And so the young ones also need to know that we are moving to digital era, although digital doesn't change anything. You are seeing the same thing on a screen basically. So, but you can do a lot of fun things with this. So that's it. So what do you think? This is benign gland or malignant? Anybody?
Malignant.
Malignant. This one is malignant? The longest gland with, you say, the rigid lumen, maybe not. What do you see in the background here? Are there tumor cells? Are there inflammatory cells?
More inflammation.
You can see better here.
Yes.
What does this gland look like?
Inflammatory cells, right?
Inflammatory cells.
More of a neutrophils.
What are the inflammatory cells? Even at this power, you can see the inflammatory cells.
More of a neutrophil cells.
More of neutrophils. Very good. Very good. Everybody has seen the slide properly. So you have these glands which are here, and you can see this. These are neutrophils. They are falling small abscess kind of micro abscess kind of structures. Okay. And again, higher power to show this collection of neutrophils here. Do you think this gland is benign or malignant?
Benign.
Benign. Anybody thinks it's malignant? Benign. Everybody agrees it's benign. Okay. And the background shows a lot of inflammation. So now why did I put up this slide is generally you have to take a dictum that prostate cancer does not elicit a lot of inflammation. You may not have a lot of inflammatory cells in and around prostate cancer glands. So if you're seeing a focus of a lot of inflammation, generally the glands which are caught up between them, the inflammatory focus, are generally part of our benign glands. Okay. So you don't break your head over those glands that they might be malignant. You have to keep that in mind. Again, things are not always 100%. But in general, if you see an inflammatory tissue in a prostate core with neutrophils, lymphocytes, granulomatous formations, the glands which are caught up within them are generally benign in nature. The same core, if you look at this is the same core. The upper end of the core has got cancer. Okay, fine. And then this patient again had probably more cancer. I think this is from the same or maybe from a different case. So anybody wants to score this score, Gleason scoring? Single gland, multiple glands, fused glands? 4? Everybody agrees these are fused glands? Or maybe complex papillary fused glands? 4 Fine? 4 plus 4. Difficult ones, again more difficult ones. Getting more. So again you have fused glands here, okay? So Suma is asking a question that's in a core biopsy. If we see a tumor involving adipose tissue, we can almost be sure that that's extraprostatic extension. Presence of intraprostatic fat is extremely rare in a core biopsy. So in a core biopsy, if you find fat being infiltrated by tumor, generally it is at the edge of the core or at one end of the core, and then we can call it a extraprostatic extension. Madam, I'll stop it here probably. It may become too much for everyone.
That's fine, Santosh.
Yes. We can take up some questions and doubts and...
Yeah, sure. If there's anybody who...
So
one question in the chat box?
Yes, sir. Yes, ma'am. One question is there. Is the NKX 3.1 is a better prognostic? better marker for the prostatic adenocarcinoma?
So NKX 3.1 is a good marker, I would say. Yeah, it does. Yeah, it's a good marker. I use it pretty much, especially in metastatic site. If you want to pick up prostate cancer, NKX 3.1 is a good marker. Generally, for a clear-cut Gleason tumor, which is 3, 4, and all, which we can see on morphology, we don't use NKX at all. So NKX 3.1 is used to distinguish from urothelial cancer or some other type of cancer, and for metastasis, NKX 3.1.
So please tell me about case 4 and case 5.
Sorry, case 4, case 5.
So someone in the chat box is asking, can you tell the diagnosis of all the cases once again?
I will share it with you. I will share it. So diagnosis is not important. I think the approach is more important. That's why I'm not giving too much. No marks for diagnosis here. Understand? Yes. So I think I'm not gone into the prostatectomy because again I'll have to take quite a good amount of time actually. So I will keep it for another day maybe.
Yeah, maybe you should ask how many people actually see radical prostatectomy.
Yes, how many people see prostatectomy? Maybe if you can put
maybe
yes.
You
no
can put it in the chat box, or any of you who are here. Srinivas,
so madam, at TMH we see only about 60 to 70 prostatectomies in a year, which is very less compared to what Verma sir would be seeing, I think.
Well, in the UK we see less because more patients go for active surveillance compared to the US. So, but to be fair, even in the US, my understanding is that the radical prostatectomy rates have fallen significantly.
Definitely come down, sir, because they are not doing that for now 3+3 and 3+4s, especially young.
Exactly, that's the reason, because you've changed the Gleason scoring, grading, and you've got grade groups, and now because you have 3+3, nobody's doing as many. It was ridiculous. 900 radical prostatectomies at the Mayo Clinic in 1 year.
I know.
I thought that was ridiculous.
Madam, there have been several editorials and several journals which they have acknowledged the fact that they have removed prostates unnecessarily.
Oh, of course.
Yeah, but, there's also the other thing here. I think it's fair to say, I don't think I'm saying anything very controversial.
Yes.
It's a fact that the reimbursement for radical prostatectomies has reduced by 1/3. So the money that is paid to the urologist for doing a prostatectomy has also reduced. Okay, may be linked, may not be linked.
Yes. So I think Apurva, you are asking about atrophic subtype of prostate cancer. So they will look like atrophic. So unless until you do a basal marker, you will not be able to diagnose them generally. So something like this, which is a very small gland, you think it's atrophic, it's blue looking and mimics an atrophic gland, but does not have basal markers, especially in a non-treated setting and all, you would probably diagnose that. It's not very common. I don't see very often atrophic prostate cancer. Verma sir, do you diagnose atrophic prostate cancer commonly?
The point is, the key question is it cancer or is it not cancer? Whether it's atrophic or not atrophic makes no difference. Okay, then you Gleason score it. So the key, it's unfortunate that we call it atrophic variant of cancer or pseudohypoplastic variant. These are just histologic